So welcome and thank you everyone for joining this first webinar of the year and ReCONNET on Ehlers-Danlos syndromes. And a special thanks to our speakers, Teresa Frank and Francisca Maffei, for their availability to run this webinar. So today we will discuss with them the clinical presentation and molecular diagnosis of the Ehlers-Danlos syndrome's subtypes, and we will have also the perspective of our loved Teresa as patient for EDS. And I would like to give just a very quick note about our two speakers. Teresa Frank is a patient with Ehlers-Danlos syndrome, and currently she is also an EPAG representative both for and ReCONNET and for Vascular, and she is also president of the Flemish Patient Organization for Connective Tissue Disorders, which is, sorry if I say incorrectly, bindwithcell.be, sorry
Yes.
for my spelling. And then we have Professor Francisca Maffei. She is a rheumatologist and a clinical genetist, and she's working at the Center for Medical Genetics in Ghent University in Belgium. And she's also the Chief Scientific Officer of the International EDS Society, and since 2017, she's also the ER and ReCONNET Senior Disease Coordinator for Ehlers-Danlos syndromes. So just a quick technical information on the webinar. So the webinar will be recorded and it will be published on the ER and ReCONNET YouTube channel, as well as on our website. And in case you want to be updated on the upcoming webinars, we will have more webinars on EDS, and you can subscribe to our newsletter on our website and follow us on Twitter as well. And in case you have any questions during the webinar, you can use the question and answer session in the chat. You can find them at the bottom of your screen. There is a black bar. You can either put your question in the chat or in the question and answer box, and both Francisca and Teresa will be available to answer your question after their presentation. So I'm going to stop sharing here, and I am going to give the floor to Teresa. Thank you again, Teresa, for your availability. You can start your presentation.
Can you see my screen?
Yes, great.
Okay, great.
Thank you.
Well, thank you for the nice introduction. Hello, everyone. Welcome. I'm very grateful to be able to start this webinar off, and I will be telling actually my story, my background on EDS and how I'm involved with it. To start off, I want to disclose that I have no financial or non-financial information to disclose, and I will start giving my presentation now. 45. 45 is a very significant number for me. It is not my age. It's not the number of years that I've been married. It's actually the 45 years. That's how long it took for me to get my diagnosis. The road to diagnosis was long and bendy, with many twists and turns. As a child, I grew up with many aches and pains. I learned that I should be tough and accept these pains and problems as part of daily life. One of my first memories of my most visible symptom was when my mother performed a typical circus or party act to demonstrate hypermobility by purposely dislocating her hip. She said, "You know, my father showed this to me when I was young because he said you are hypermobile and you should never do this because this will only wear out your joints." So, no party tricks. My grandfather was a surgeon and he unfortunately passed away 5 years before I was born. During my teens, I immigrated from Europe to the States with my family. There in high school, I did started doing sports because my grandfather and my mother had said that we had to sport and exercise to make our muscles strong because that is what's keeping us together. And you have to think, when I'm born in the 60s. In the States, I just joined high school and I had different sports. I played basketball, I played softball, and when I played basketball, our team was state champion for several years in a row. So you can imagine how intense and hard and intense our practices were, and they were daily. My coach had to tape my ankles, elbows, knees, and wrists as I had many injuries. I also had so many bruises over my whole body where I wasn't taped or even underneath the tape that the school physician sent me for a leukemia checkup because they were so concerned. In the weekends, my parents made me also go hiking, rock climbing, skiing, canoeing, or any other very contact or active sports. I remember many sleepless nights when I woke up crying from the pain. Sometimes it was so bad that my parents took me to the emergency department. There, I was told, as many as other patients will say, it's just growing pains. It's in your head. It just seemed that I would just fall over air. And also, when I was a teenager and my menstruation came, I had so much pain that I could not sit and had excessive bleeding problems. During my senior year, I stopped school sports because it was just too painful. Not only did I have painful joints, I was dislocating a lot. I was having fainting problems for no apparent reason or cause, and headaches and severe headaches almost became a daily occurrence. Next to that, I also have gastrointestinal problems and other things. My mother once again just told me to accept it and live with it. Then, as I grew up into my 20s and married, I had many different problems. From skin, organs, joints, internally, externally. I also had several miscarriages, but finally had a first full-term pregnancy where I developed preeclampsia very early on and was hospitalized for 5 months. When my eldest was born, and this is like more than 30 years ago, I only remember being wheeled into the operating room and screens placed over my chest around me. The next thing I remember is actually waking up the next day and everything was behind. Just to find out that I had bled out so much that they had to give me several bags of blood, as well as that I had passed out and the staff was covered from head to toe from blood. So the fourth day of my new baby's life was a big blur. I developed, or I got a lot of scars from this pregnancy, from all the different IV points from over the 5 months, as well as, well, you can't not actually call it stretch marks because with the onset of preeclampsia, or my skin ripped open and started bleeding due to the sudden swelling of the preeclampsia. And then it started scarring. In the States, over the years, I also had different surgeries for different purposes, and it became evident that the anesthetic procedure was problematic for me. It just did not take, or I would wake up. When my oldest was a toddler and she was born in the States, also she started having many pains just like I did. And what did I do? I just, like my mother said, it's growing pains. I moved back to Europe and I had my second and third pregnancy. I had many hip problems, as well as excessive bleeding. My stretch marks even got wider and my stomach looked like a battlefield. The skin after the last pregnancy, the third one, did not go back even after guided exercise and physical therapy. Over the years, back in Europe, I had several shoulder operations, which resulted in frozen shoulder, muscle atrophy, and more. I only had 4 to 6% use of my shoulder, arm, and hand. It took about 3 years with very painful therapies to get back to the normal use of my hands, or almost normal use of my hands and shoulder. Then my children were growing up. I observed that many of them had problems just like I've had all along, and there must be something genetic going on. I started actively searching for a correct diagnosis again. I saw many different doctors, all specialized in their own area, every time for another symptom. My eldest and I had such sensitive skin that we were both tested clinically positive for a rare skin disease. In the meantime, I also had different types of aches and pains and gastrointestinal problems, fainting, just like I did before. I started collecting from all these different specialists, different diagnoses, anything from fibromyalgia, CVS-ME, damaged spinal joints, neurological issues. The list goes on and on. At some point, it was even questioned if I had Munchausen, and Munchausen by proxy, as all my children were often in the ED with dislocated joints, bruises, gastrointestinal problems. Luckily, that got disproved rather quick in comparison to some other patients. In addition, my gallbladder was removed not so long ago, and at the time, they still thought I had this rare skin disease. So it was decided by the surgeons that they were going to do the classical procedure. I have now an atrophic scar from almost 3 centimeters wide and 12 centimeters long across my liver area. So next to all the other scarring that I have, my stomach area is really a battlefield. The year for my diagnosis, I also went several knee operations and received my first knee prosthetic. The epidural and anesthetic did not work, and I woke up during the operation, feeling and hearing everything. The operation caused for me to stay in the hospital for 6 months due to bad wound healing and progress. This experience and the Munchausen experience led me to desperately start doing my own research. I ended up finding my way to the University of Ghent Genetics, armed with a large thick binder with medical records. I was 45 years old when my youngest and I received the diagnosis Ehlers-Danlos type 3, now known as hypermobile EDS. Every patient is different from one another. So are all the symptoms or the severity of symptoms different from within my own family. If only the physicians seen over the years had more knowledge of the symptoms or puzzled the pieces together, maybe we would receive the right diagnosis sooner. I'm at least grateful that at the time of their diagnosis, my children were young adults or younger, so that they could start taking better care of their bodies and choose vocations more suitable that would enable them to continue working in the future. My body is worn out as I had not taken proper care of my body. If I had known that I had EDS, I would not have proceeded with some of the surgeries and lived and approached my life differently. I have learned that EDS comes in many phases. There are not only different types, but especially the hypermobile EDS that I have, it comes in many phases, many gradations. Not one person is the same. EDS can be quite debilitating and degrade the quality of life, even when one receives the right treatment or with the assistance of mobility aids. EDS has a big impact on the life of the patient and his or her surroundings. Please take every patient seriously, as they are in need of your understanding and newly growing expertise. It is my goal to help spread awareness so that other patients will not suffer as I have done, and that my children will have another life than I had. I am so thankful that the technology research of today help facilitate the EDS experts, the International EDS Society, European Reference Networks, ReCONNET, and others, so that the awareness, diagnosis, treatment, and care and knowledge becomes available for all. Thank you for listening to my story and for your willingness to increase your knowledge through attending this webinar. Thank you.
Thank you very much, Teresa, for this very touching story and a very important message you have launched at the end of the presentation. I think it's really important. So if you agree, we could leave the question at the end of the webinar, or do you prefer to answer now?
At the end is fine.
Great. So if it's okay, then we can give the floor to Professor Malfay. Please, Francisca, you can start. Thank you.
Yes, thank you. First of all, can you see my screen?
Yes, we can. Very clear.
Thank you very much. So I would also like to thank all participants that are present here today in this webinar, and I would like to specifically also thank Charissa for her indeed touching story, and probably something that at least some of the patients that are among the public here is a very recognizable story. So this webinar is not only dedicated towards patients, but also towards doctors. So for the patients, it might sometimes maybe a little bit hard to follow. I apologize already for this. And I think there might also be a series of webinars that will be planned in future that is specifically addressed to patients. So we will try to tackle it then in a more accessible way. So I would briefly like to start with some history, because I think it's really important to know how the story of EDS started, to also understand how we think about this syndrome now, and where we are coming from over the past 30, 40 years. So the Ehlers-Danlos syndromes have fascinated people really throughout the ages. On the left side of this slide, you can see the first photograph of a patient with EDS. His name was Felix Weerle, and he was also known as the elastic skin man. And for many years, no fairground was complete without an elastic skin man, an elastic lady, an India rubber man, or a human pretzel. Collectively enjoyed as curiosities, many affected individuals earn their livings by amazing their audiences with their tricks or their astonishing ability to stretch their skin. And we already heard from Teresa also that she was used to doing these party tricks when she was a child. The first medical description of some of the characteristics of Ehlers-Danlos syndromes, or EDS, I will say from now on, is credited to Job van Meekeren, and he was a Dutch surgeon from Amsterdam who in 1657 observed a Spanish boy who had extreme extensibility of the skin, as you can see on the drawings, but very unusually in this person, it was on the right side of his body. Ooh. Sorry, I lost my slide. Credit for the first comprehensive description of a syndrome displaying laxity of the joints and fragility of the skin goes to the Russian dermatologist Chernogubov. His report was, however, largely overlooked in Western Europe, probably because it was written in Russian. And then two dermatologists, Edward Ehlers and Henri-Alexandre Danlos, separately described affected individuals in 1901 and 1908. And as such, this syndrome received its eponymous title of Ehlers-Danlos syndrome, and thus also became scientifically respectable. Those first clinical descriptions share the presence of the major hallmarks of EDS, the combination of hyperextensible and fragile skin with loose jointedness or joint hypermobility. And that's what we consider something to be an Ehlers-Danlos syndrome, when you have at least the combination of these symptoms. Early clues to the pathogenic basis of EDS came from ultrastructural or electron microscopic studies of the skin and other tissues of patients with EDS. In 1955 already, Janssen, a Dutch dermatologist, studied the skin of two patients with EDS by means of electron microscopy, and he concluded we believe that the whole EDS is based on the existence of the insufficient twining of collagen elements in the dermis, the hypodermis, and the joints, thus suggesting for the first time that the defect underlying EDS affects the collagen wickerwork, as he called it. Further clues to an important role for collagen abnormalities in the physiopathology of EDS came from biochemical studies in the 1970s. So in 1971, Lapierre and co-workers identified a defect in the conversion of procollagen, which is a precursor molecule of collagen, in tissues of cattle with a form of Ehlers-Danlos syndrome that is called dermatosparaxis, and dermatosparaxis is Greek for torn skin. And the dermis, or the skin of these animals, was shown to contain loosely packed, thin and twisted collagen fibrils with a very abnormal shape. And then biochemical studies revealed that these animals failed to process this precursor form of procollagen to the mature collagen form. And so premature collagen molecules were built in the tissues, and these premature collagen molecules are called PN molecules. And then 2 years later, Lichtenstein and co-workers identified 3 human patients, and in those patients who had joint hypermobility and congenital bilateral dislocation of the hips also had an accumulation of these precursor PN collagen molecules in their tissues. And then a second biochemical clue for the involvement of collagen came from studies from Pinel and co-workers who found a deficient hydroxylation of lysyl residues, again in collagen, in 2 siblings, 2 sisters with a form of Ehlers-Danlos syndrome characterized by severe scoliosis, joint hypermobility, and skin fragility. So they found an abnormal modification of collagens in these sisters. And then in 75, Mike Pope in the UK also found abnormalities in collagen, but this time on post-mortem tissues, samples from a patient with what was later known as the vascular or the arterial type of EDS. And he found a deficiency of type 3 collagen in the skin and in the aorta of this patient. So that was the 1970s, and in that time there were only biochemical clues to the diagnosis of EDS, but still no genetic or no molecular defects. And then with the introduction of sequencing genetic techniques in the 80s, the first mutations or genetic defects were being identified in genes encoding type 1 collagen and then also type 3 collagen. And the combination of ultrastructural, biochemical, molecular, and also clinical studies made it clear that EDS was not one disease, but a clinically and genetically very heterogeneous group of conditions characterized by, as we already have seen, skin hyperextensibility and fragility, joint hypermobility, and generalized friability, mainly of the soft connective tissues, including vascular fragility. And the title of this webinar is Ehlers-Danlos syndromes. It's a disorder with many faces, and I'm just showing here you here a few of these faces. These are all different types of Ehlers-Danlos syndrome, and as you can see, there are indeed a lot of different presentations. It is indeed a very heterogeneous disorder. And as Teresa also said, even within one subtype, we can see also a whole range of variability. So one of the main manifestations indeed is joint hypermobility, can be very severe, can also be rather mild. It can lead to recurrent dislocations or subluxations and instability of the joints. It can lead to proprioception problems. It can lead to inflammation of the tendons and the joints. And one of the main problems indeed often is chronic pain that is very, very difficult to treat. other abnormalities that we can see of the musculoskeletal system is scoliosis, kyphosis, pectus abnormalities, foot abnormalities with hallux valgus, hammer toes, very flat feet or club feet, congenital hip dislocation. All of these things can be present, and we can also see them in many different types of Ehlers-Danlos syndrome. One of the main hallmarks and often really a clue towards the diagnosis of EDS is the skin. It's very important to look at and touch the skin to be able to make a diagnosis of EDS. It really depends also on the subtype and on the underlying genetic defect, how the skin presents, but one of the main hallmarks are indeed the skin hyperextensibility. This means that the skin, you can very easily lift it up, but it will snap back when you release it and take its normal shape again, which is different from cutis laxa, where the skin really hangs in loose folds around the body. Patients have a fragile skin that tears very easily and then can heal very slowly with the formation of these thin atrophic scars or cigarette paper scars that you can appreciate on some of these pictures. In some forms, the skin is very thin and translucent, and you can very easily see the veins, and that's especially true for the vascular type of Ehlers-Danlos syndrome, but I will come back to that. And then sometimes you can also see these discolorations, especially on the shins, that are often the result from repetitive lacerations, but also the easy bruising that we see in many forms of Ehlers-Danlos syndrome. In 1997, the Villefranche classification for Ehlers-Danlos syndrome was developed, and you can see the Villefranche classification on this slide. It recognized 6 subtypes of EDS based on clinical characteristics, the mode of inheritance, and if it was already known, the biochemical or molecular causes. And so the major types were the classical hypermobility and vascular type, caused by defects in either type 5 collagen or type 3 collagen. For hypermobile EDS, the cause was and is still not known. And then the more rare subtypes were the Kyphoscoliosis, Arthochalasia, and dermatosparaxis type. But all of them were in some way or another caused by defects in one of the collagens, type 1, 3, or 5, or in a molecule that is involved in the maturation of these collagens in the extracellular matrix or in the connective tissue. And for about 20 years, this classification really was the gold standard for identifying, classifying, and diagnosing the different types of Ehlers-Danlos syndrome. So when we look at the classical type of Ehlers-Danlos syndrome, previously also known as EDS type 1 and 2, so this is an autosomal dominant disorder, which means if you have it, that your children, if it either boys or girls, will have a 50% chance of inheriting the disease. It has an estimated prevalence of about 1 in 20,000 newborns. However, this might be an underestimation because like for other types of EDS, it might be that there are still many people out there that are simply not diagnosed. We heard about the diagnostic odyssey, and that's certainly also true for classical EDS. It is caused by mutations or pathogenic variants in the genes that code for type 5 collagen. And type 5 collagen is a fibrillar or fibril forming collagen that is present in the tissues together with type 1 collagen, and it forms these fibrils that you can see there on the microscopic picture. So together with type 1 collagen, and studies in human with classical EDS and in mouse models for classical EDS have really revealed that type 5 collagen is a very important molecule that has a key role in the organization of the collagen fibrils in the extracellular matrix. So here you can again see some of the major characteristics of Ehlers-Danlos syndrome. So I think in this type, the skin hyperextensibility is really very clear. The atrophic scarring can be quite severe and also lead to aesthetic problems. Bruising in places where you would normally not expect bruising, such as on the forehead or on the back or on the pectus here, can be present, and indeed in some children with classical EDS there might even be a suspicion of child abuse because of the unexplained bruising and scarring. Patients can have quite a pale face also with epicanthic folds, and then the joint hypermobility is usually also quite severe, although as in all types we can see a large variability. The major hallmarks are thus the skin hyperextensibility with the atrophic scarring in combination with generalized joint hypermobility. And generalized joint hypermobility is assessed with what we call the Beighton scale for joint hypermobility. This is a 9-point scale that you can see here on the right side, in which you assess joint hypermobility in a number of joints. And a score of at least 6 out of 9 is considered to reflect generalized joint hypermobility in pre-pubertal age, whereas in adults up until the age of 50, a score of at least 5 out of 9 is considered positive. And then you can see here a list of other manifestations of classical EDS, which all are manifestations of connective tissue fragility. There is one specific form of classical EDS on which I would also like to draw your attention. It is a form that clinically is a little bit in between classical and vascular EDS, and it is caused by a very specific abnormality, not in type 5 collagen, but in type 1 collagen. And so it's a mutation that substitutes an arginine to a cysteine. It's a very specific mutation. And this mutation was first identified in 2000 and in 2 unrelated children that you can see here that really presented a typical presentation of classical EDS with the joint hypermobility, skin hyperextensibility, atrophic scarring, etc. And you can also see one of these patients, the boy, we recently saw him back here in our clinic. He's now somewhere in his early 20s, and you can clearly see also again that the skin scarring, etc. On the legs really has progressed, and he also developed a very severe pectus abnormality. However, very importantly, a few years after this, we identified the exact same mutation in a woman that was referred to us because there was a suspicion of vascular EDS, because she had a spontaneous rupture of a large artery in her abdomen in her early 30s, and so it was also a spontaneous rupture, and we did not find an abnormality compatible with with vascular EDS, but we found the same mutation in collagen type 1. And so this mutation has now been reported several times in families presenting a phenotype that mimics classical EDS, sometimes with and sometimes without the presence of arterial rupture. And it is a very important differential diagnosis of both classical and vascular EDS. So this then brings me to the vascular type of EDS, previously known as EDS type 4. It is also a dominant condition with a prevalence that is estimated to be between 1 in 200,000 and 1 in 50,000 newborns. And this condition is caused by mutations in the gene that codes for type 3 collagen. Type 3 collagen is also a fibril-forming collagen that also is present together in specific tissues together with type 1 collagen. And it is specifically present in what we call elastic tissues, such as skin, but very importantly also in the walls of blood vessels, in the wall of the stomach and the intestines, the uterus, but also lungs, liver, and spleen. And it is probably also in some way or another involved in organizing the collagen fibrils in the extracellular matrix. So what are the major clinical criteria for vascular EDS? Well, it's a dominant disorder. So if there is a family history of vascular EDS with a documented mutation in type 3 collagen, then obviously that is a very important reason to rule out it's present in that patient. But when should you particularly think about vascular EDS? That is when there is an arterial rupture at a young age. When there is a spontaneous perforation of the gastrointestinal tract, mostly of the sigmoid colon, but actually it can be everywhere in the gastrointestinal tract up to the esophagus, in the absence of predisposing factors. When there is a uterine rupture during the 3rd trimester in the absence of a previous cesarean section, or when there are very severe peripartum perineum tears. And then quite rare, but very specific for vascular EDS is when there is a fistula, a carotid cavernous sinus fistula in the absence of trauma. Here you can see some of the other features that we see in patients with vascular EDS. In contrast to the other types of EDS, patients with vascular EDS do not show this skin hyperextensibility, but they have the very thin and translucent skin. They have easy bruising, but I should stress that easy bruising is something that we see in all types of EDS. So it's not because you have easy bruising that you have vascular EDS. We do see it across all the types of EDS. Early onset varicose veins is also something that should prompt or make you aware of vascular type of EDS. And then often, but certainly not always, patients, affected individuals may have quite a characteristic facial appearance. The pictures that you see here are quite obvious. So with protruding eyes, large eyes, hollow cheeks, a thin pinched nose, thin lips, but it's not always that obvious. So you can easily miss that. And then the joint hypermobility is usually restricted to small joints and not generalized. So it's usually mostly the finger joints that are hypermobile. And patients are at risk for tendon and muscle rupture. They can be born with a hip dislocation or with club feet. And something that we also see more often is a spontaneous pneumothorax or repetitive pneumothorax or a pneumohemothorax. I'll just go back. With regards to the arterial rupture, I would also like to stress that in contrast to other connective tissue diseases such as Marfan syndrome, very often these ruptures are not preceded by aneurysms. So there is really not any way to predict where and when a patient will develop a arterial rupture. So it's very important to keep that in mind, and therefore also the regular use of imaging to detect aneurysms, etc., is much less clear than for instance, for Marfan syndrome. This brings me then to another type of Ehlers-Danlos syndrome that was already recognized very early on. It's the Arthochalasia type of EDS. So this is another group of EDS that is caused by very specific mutations in type 1 collagen. Normally, actually, mutations in type 1 collagen give rise to another connective tissue disorder, osteogenesis imperfecta, which is characterized by bone fragility with multiple fractures. But there are these specific mutations in type 1 collagen that give rise to specific types of Ehlers-Danlos syndrome instead of osteogenesis imperfecta. And so the Arthochalasia type is one of them. And as you already heard in the introduction, this condition is caused by very specific defects in one of the genes that codes for type 1 collagen, and it's a defect that deletes the cleavage site, the site where the amino proteinase will cleave off the amino terminal propeptide of type 1 collagen. So you see here this is extension. So this is type 1 collagen, and this will form the fibrils in the connective tissue. And so at both sides of type 1 collagen, you have these extensions, and they need to be cleaved off. They need to be cut before you can actually make these fibrils in an orderly way. And it's very important that this is done in the correct way. So in the Arthochalasia type, there is a specific defect in type 1 collagen that prevents the enzyme to cut off this side of the collagen. And as a result, immature, larger collagen molecules will be built in the connective tissues, and this will lead to the fragility of the connective tissues. And this form is very specifically characterized by the presence of bilateral, so on both sides, dislocations of the hips at birth, in combination with usually very extreme joint hypermobility. So if we see that combination, so the congenital hip dislocation should always ring a bell towards Arthochalasia type of EDS when it's in combination with joint hypermobility and skin hyperextensibility. And since it's a defect in type 1 collagen, we also often see some fragility of the bones with osteoporosis. In contrast, there is another type of Ehlers-Danlos syndrome, the dermatosparaxis, and remember the cattle that was first identified with the torn skin. Well, in 1992, there were a few human individuals that were identified that had the same form of Ehlers-Danlos syndrome. And here it's also a defect in cleaving of this amino terminal propeptide of type 1 collagen, but the defect is not in the collagen itself, but in the enzyme that cleaves of this propeptide. And in contrast to the Arthochalasia type of EDS, the hallmarks here are very extreme skin fragility. You can see here on the pictures that the skin is really looking more severely affected than what you have seen. There are also tooth abnormalities. There can be very extreme bruising, and joint hypermobility is usually a little bit less severe. Another type of EDS is the Kyphoscoliotic type of EDS. So this was actually the first inborn error of human collagen metabolism that was detected at the biochemical level. Lysyl hydroxylase 1. It is an enzyme that is very important in modifying the collagen molecules during their maturation. They put a lysyl residue on one of the amino acids in collagen, and these hydroxylated lysine residues that are formed, they have two very important functions. They are essential for the stability of the crosslinks that provide collagen fibrils with their strength, their tensile strength, and their mechanical stability. And they also serve as attachment sites for carbohydrate units. And all of this is just very important in the function of collagen in the connective tissue. As a result of this underhydroxylation of the collagens, they will display a faster electrophoretic mobility on this biochemical analysis that you see here on the right side. And that is something that was in the old days before genetic analysis was so readily available, something that was used in the diagnostic workup of patients with EDS. It was one of the reasons, one of the things that we did on a skin biopsy, and one of the reasons that we always asked for a skin biopsy. But nowadays, this is replaced by genetic analysis, and usually we do not need a skin biopsy anymore to do the genetic analysis. And we start from a blood sample. The clinical characteristics here are again joint hypermobility, but usually patients have a very severe scoliosis or curvature in the back, or kyphoscoliosis. And also at birth, they can have a very severe hypotonia, so muscle weakness, that can also lead to the suspicion of a muscular disease or a neurological disease instead of a connective tissue disorder. And then some of these patients are also at risk of a rupture of the eye because there is a fragility of the tissues in the eye, and also a bit like vascular EDS to arterial rupture. So now we have heard about a lot of problems in the collagen, and for a very long time, EDS was considered really a paradigm disorder of collagen. But in the post-Villefranche era, so starting in the beginning of the 2000s, there was a proliferation of EDS types, both clinically and genetically, that was not incorporated in the Villefranche. And so, for instance, deficiency of tenascin X was the first non-collagen defect that was associated with a form of EDS. So total absence of tenascin X was found to lead to a condition that clinically really resembles classical EDS with the same degree of skin hyperextensibility and joint hypermobility, however, without the atrophic scarring, and also with a different mode of inheritance, an autosomal recessive inheritance. And further characterization of new patients later on also showed other signs such as progressive contractures, severe foot deformities, gastrointestinal problems, and then also peripheral edema that is not explained at this point. Tenascin X is also a molecule that is very important in the extracellular matrix, and that actually has also been shown to be involved in organizing the collagen fibrils in the connective tissues. Then already in the 70s, it was recognized that there were patients that had a phenotype that resembled the Kyphoscoliotic type of EDS. Remember, the one with the severe kyphoscoliosis and the rupture of the eye globes, but that did not have abnormalities in that lysyl hydroxylase. And on the left side, you can see two siblings that were described in 1975 with this condition. And this was called EDS type 6B, whereas EDS type 6A was kyphoscoliotic type with lysyl hydroxylase deficiency. And then in 2010, our Japanese colleagues, Tomoshi Kosho and his colleagues, reported a series of Japanese patients, and you see a few pictures here, displaying a very similar clinical presentation. And they called it EDS Kosho type at the time. And then simultaneously, we also had a few families that had a very similar presentation. And so all of these were described a little bit in parallel, and we call them musculocontractural EDS. But in the end, we all found mutations in the same gene, which is called CHST14. And CHST14 is a gene that is not involved in forming collagens, but it's involved in forming other very important molecules in the extracellular matrix, which are called proteoglycans. Proteoglycans are very abundant together with collagen in the connective tissue. And they consist of a protein, which is called a core protein, which you see here on the right side. And then they have one or more glycosaminoglycan side chains, such as heparan sulfate, chondroitin sulfate, and dermatan sulfate. So these are actually sugar chains. And CHST14 specifically is involved in the conversion of chondroitin sulfate to dermatan sulfate, as you can see here. And one proteoglycan that is very important in the pathology of EDS is decurin. And decurin is a proteoglycan that contains a core protein here depicted in purple. And it has one glycosaminoglycan chain that is dermatan sulfate. And as you can see here, decurin is present around the collagen fibrils. And through this sugar chain, it is also involved in organizing collagen molecules and fibrils in the extracellular matrix. And we and our Japanese colleagues have been able to show that due to the defect in CHSD14, the dermatan sulfate is replaced by chondroitin sulfate, and the chondroitin sulfate cannot regulate the collagen fibril deposition as nicely as the dermatan sulfate, and as a result, again, we see abnormalities in collagen fibril deposition. So after the identification of mutations in CHSD14, defects have also been found in a few other enzymes that are involved in the synthesis of these glycosaminoglycan chains. And I'm not going to go into detail into the function of all these enzymes specifically, but here you can see one of these conditions that is now called spondylodysplastic Ehlers-Danlos syndrome. You can see this is a very severe condition, again with contractures, scoliosis, joint hypermobility, tooth abnormalities, abnormalities of the hands and feet. And here also specifically, you can see a form of skeletal dysplasia on the x-rays that is quite typical for this type of EDS. And so by now, multiple enzymes have been involved in different types of Ehlers-Danlos syndrome. And for time's sake, I'm going to skip this one. But as you can see now, together with an international consortium of EDS specialists in 2017, the Villefranche classification of EDS was revised because there were so many new clinical and genetic subtypes that had been identified since 1997. And so now there are 13 subtypes there were 13 subtypes that were being recognized with mutations in 19 different genes. And this was published in 2017, and actually a year later already an additional type of EDS was identified. So this list is still growing. For the last 5 minutes, I would also like to talk a little bit about the hypermobile type of EDS, but this will also be addressed during one of the following webinars by Dr. Castori, who will talk about hypermobile EDS and hypermobility spectrum disorders more in particular. So as we all know, hypermobile EDS, the genetic cause of this condition is still unknown. And just a few words about generalized joint hypermobility. So generalized joint hypermobility actually has a very high prevalence in the general population. In the pediatric population, this ranges, depending on the studies, between 7% and 36%. In the adult generation, between 2 and 57%. So you see a very large range also. It's influenced by many different factors, including age, gender, and ethnicity, but also connective tissue pliability, muscle tone, physical activity and training, etc. And we do see that there is something as familial joint hypermobility, and heritability studies in twins have shown that the heritability of joint hypermobility is approximately around 70%, however, with a very large variability in presentation and severity. In the Villefranche nosology, criteria were developed to make a diagnosis of hypermobile EDS, and they were based on a Beighton score of at least 5 out of 9 and some skin involvement, and then recurrent joint dislocations, joint pain, and a positive family history. And then in parallel, in 2000, Professor Graham in London developed the Brighton criteria, which is a bit confusing with the Brighton score, and here the Brighton criteria for joint hypermobility syndrome. And here you can see you need a Brighton score of at least 4 out of 9. You also see pain in this list, but a little bit confusingly, also manifestations of skin fragility or other connective fragility are incorporated in this list for joint hypermobility syndrome. And so at one point, these two conditions were considered to be one and the same disorder by many, and the terms were used interchangeably, both in clinical and in research setting. And this created actually a lot of confusion, whether hypermobile EDS and joint hypermobility syndrome are one and the same condition or not, etc. In the new classification that was published in 2017, therefore, a more restricted set of criteria for hypermobile EDS was developed. And the diagnosis of this condition now rests on the presence of generalized joint hypermobility, taking into account that joint hypermobility will decrease with age. So there is now an age-dependent Brighton score. And then we have to be sure, and I look at point 3 here, we have to be sure that there is no other type of EDS involved. There is no other connective tissue disorders such as Marfan syndrome, Lewis-Dietz syndrome, osteogenesis imperfecta, or any other condition that can explain the joint hypermobility. And then in order to receive a diagnosis of hypermobile EDS, you have to have at least 2 out of 3 of the following. Either you have to have manifestations of skin, fascia, or connective tissue manifestations, and I will show this on the next slide. At least one first-degree family member that independently meets these diagnostic criteria, and or musculoskeletal manifestations of musculoskeletal pain in 2 or more limbs, recurring daily for at least 3 months, chronic widespread pain for at least 3 months, or recurrent joint dislocations or frank joint instability in the absence of trauma. And here you can see the list of the connective tissue manifestations that are needed to make this diagnosis. And you need to have at least 5 of these. And as you can see, these are all signs of connective tissue fragility: soft skin, velvety skin, hyperextensible skin, prolapses, some mild Marfanoid signs in the absence of a true Marfan syndrome, etc. People presenting joint hypermobility and all the associated problems of the joint dislocations, pain, etc., who do not fulfill the criteria, who do not fulfill criteria for another type of EDS or another heritable connective tissue disorder, or do not have other genetic or non-genetic causes for their joint hypermobility, are now diagnosed with hypermobility spectrum disorder. And for those interested in this, I refer to the publication by Marco Castori in the American Journal of Medical Genetics from 2017. So last year or 2 years ago, the ERN ReCONNET working group on Ehlers-Danlos syndrome did a literature review on the state of the art on clinical practice guidelines for Ehlers-Danlos syndrome. And as you can see here in this publication, it detected an absence of papers reporting good quality clinical practice guidelines to optimize patient care. And so one of the conclusions is indeed that there are many clinician and patient unmet needs that were identified during this task, and so there is still a lot of work to do to develop these clinical practice guidelines, both for diagnosis and especially also for management of the Ehlers-Danlos syndromes. So when do you have to think of an Ehlers-Danlos syndrome? It's very important to start with a very good clinical history taking and examination. And so you must have clues to tissue fragility affecting at least 2 body systems. So only joint hypermobility is not enough to make a diagnosis of Ehlers-Danlos syndrome. And so in the classification that is out there now, major and minor clinical criteria were developed that can guide the diagnosis. It's very important to look at the family history, and this can give you clues to, for instance, autosomal dominant or autosomal recessive inheritance patterns. Really depending on the family and the personal history of the patients, you can do some additional investigations such as ultrasound of the heart, an eye exam, an exam of the ears, skeletal x-ray, bone densitometry, etc. But it's not something that one should do in every patient that presents with a suspicion of EDS. It really depends on the history taking. And then referral for genetics to do a molecular confirmation for all types where there is a gene known is very important. As I have shown you, for instance, with the classical and vascular EDS, you can still have a clinical overlap, and it's really important to make the difference. So here you can see a few pictures and overlapping presentations with mutations in different genes that show the exact same skin or foot or abnormalities or scoliosis. So the genetic analysis nowadays is based on sequencing of all the genes, usually in a panel. So we sequence all the genes for EDS in one row. Sometimes these panels also involve genes that are associated with other connective tissue disorders, such as Marfan syndrome. It starts usually from a blood sample, and a skin biopsy is not really necessary in most cases anymore to do the diagnosis. And so I will stop this introduction to EDS, the very complex world of EDS here. I think I have shown you that EDS has evolved from a virtually unknown condition to a very heterogeneous group of multisystemic connective tissue disorders, that the combination of the in-depth clinical evaluation with all the ultrastructural, biochemical and molecular studies has been very instrumental in identifying and classifying the EDS subtypes. It's really important to very look in detail at your patient, because clinical hallmarks can really help to differentiate between the phenotypes. But as I have also shown, molecular analysis is mandatory for accurate diagnosis, management, and genetic counseling. And increasing identification of novel genes and pathways is giving us still new insight into the pathogenesis of this disease, which is now considered a collagen-related connective tissue disorder. And hopefully, by increasing our understanding through the identification of all these pathways, this will also lead the way to better therapies. And unfortunately, and very frustratingly for many among us, the genetic basis of hypermobile EDS and hypermobility spectrum disorder remains unknown and a topic of a lot of research. And just at the end of this, I have listed a few recommended articles and a special issue of the American Journal of Medical Genetics in which you can find the classification of EDS and also a bundling of literature review on many different topics of Ehlers-Danlos syndromes. And with this, I would like to thank the patients and the families that throughout the years have contributed to this research, my colleagues at the Center for Medical Genetics, and also my international colleagues from the International Consortium for EDS and EDS Society that were very helpful in the classification of EDS. Thank you.
Thank you very much, Franziska, for your presentation. We have some questions. If you still have time, we can go maybe through a couple of them, if it's okay.
Yes.
So the first question is from Valerie. Can you explain the difference between HSD and SEDH? Because it is said that the sick HDS and the SEDH is the same thing. Is HSD more serious than HEDS? HSD. So I don't know if you see the questions. Can you
Wait,
see them?
yeah, it stops.
Okay.
Can you explain the difference between hypermobility spectrum disorder and hypermobile EDS? I'll just say it without the abbreviations because that might be more clear. So again, this will be a specific topic of a webinar by Dr. Castori. It is true, absolutely true, that the pains and the symptoms and complaints in HEDS, hypermobile EDS, and in hypermobility spectrum can be the same. There are patients with hypermobility spectrum disorder that are much worse also with regards to disability, pain, impact on their mobility, on their daily functioning, and quality of life that are worse off than hypermobile EDS. So no, EDS is not necessarily more severe than HSD. So we do see variability in both conditions. The main difference between hypermobile EDS and hypermobility spectrum disorder is that in hypermobile EDS, the connective tissue fragility apart from the joint hypermobility, so the fragility and signs in other tissues is a bit more clear. So the skin is a bit more clearly affected. There might be a bit more bruising. We might see prolapses of internal organs. We might see a bit more scarring, but there is certainly still a gray zone between the two. But to answer your question, no, the one is not worse than the other.
Then we have another question from Valerie. When we have a genetic feedback of which one allele is deleterious, can we consider the patient still sick with this gene, knowing that the patient has the symptom concerning the allele involved?
I'm trying to understand the question. I think so. I'll just try to explain a little bit very basically about genetics. So of every of the genes involved in Ehlers-Danlos syndrome, the collagen genes and all the other ones that you have seen, we have two copies, one that you inherit from your father and one that you inherit from your mother. In an autosomal dominant condition, such as classical EDS or vascular EDS, it is enough that you have a defect on one of these two copies, and these copies are called alleles. So it is enough that you have a defect on one allele, even if you still have the other allele that is normal, to develop the disease. This is in contrast to some forms of EDS that have an autosomal recessive inheritance, which is different. In an autosomal recessive condition, you will only develop the disease if you have two copies, two alleles that have a mutation, that are deleterious. So that means that from both parents, you would inherit a copy or an allele with a defect. I don't know if that was the question, but that's the only sensible thing that I can answer to that.
Thank you very much, Francisca. We have another question. Is oxygen considered a useful drug for HEDS around the world?
Well, as far as I know, there are no clinical studies that have been conducted with oxygen specifically in a group of patients with hypermobile EDS comparing with the group that do not receive oxygen. And so there is no evidence, scientific evidence as far as I know yet. I know that in some countries it is given very regularly, and that some people feel better with it. In Belgium, it is not given, and it is not also reimbursed, as far as I know. So there is no proof. But I mean, yeah, there are people who feel better with it. So that's another thing. But there is no proof.
That makes sense. Thank you. We have a question from Francisca Fontes. It's about a case. Maybe, Francisca, if you agree, we could forward you this question related to a case. Then you can answer to this very specific question.
Okay.
And then we have someone asking if you can please share your last slide.
Okay. I don't know, Carissa, if you have anything to say about the oxygen. Maybe from a patient perspective, you have more information about the oxygen.
Well, I saw that the question came from France. I know in France that they are using oxygen as for the patients, and that has made them feel better. There were some internal studies, from what I understand. There weren't extensive research, so it is not completely evidence-based. But I know that in the French-speaking part of Belgium and in France, oxygen has been applied. And from what speaking to the patients and also some of the Flemish patients who have tried it as well, they are pretty positive of the outcome. I think that it should be studied probably more in the future, but yes, they've had some good outcome, but it's I think it's only in France and in parts of Belgium that they apply this.
I have no experience with it, so that's, yeah.
Thank you, Teresa.
I'm not sure if this is the slide that people wanted to see, but I think the webinar will also be posted on YouTube. So
yeah, so you will be able to see again the slides and go through the webinar in all tranquility in your homes. So we have. I would leave another question, maybe if you agree. If Danielle is asking if there is a link between the HLA-B27 and the hypermobile EDS.
No, there is no link. No link between those two.
Okay, thank you. Are there any differences in the treatment between the hypermobile syndrome and the hypermobile EDS?
Mostly not. I mean, the treatment of the musculoskeletal manifestations can really be very identical between these two groups. I think we just have to take into account if a patient has a bit more signs of connective tissue fragility, for instance, if there really is quite extensive bruising, that would also affect the degree of physiotherapy that you can do. So you have to take into account the whole history of the patient, but basically not really. No big differences on with regard to the musculoskeletal problems.
Okay, so I think we have to close. We have passed the 1 hour and 20 minutes, yes. So we can close now. And I would ask the remaining attendees that had questions to either send us your questions via email, or you can also add your questions in the YouTube channel when we're going to publish in the next days. We might see quite a few questions there. So that would be the best way. We will try to forward this question anyway to Francisca, and we'll see which way we can answer them. So thank you very much. I just wanted to add that once the webinar will be closed, a new window will pop up and it's the survey that we have developed to monitor the quality and the satisfaction of our webinars. So if you can please answer also to this very quick survey, that will help us to improve our quality in the future. And I would say thank you again to Teresa and to Francisca, and we will get back to you with a lot of new webinars on EDS, so you will be able to see a lot more. And thank you for joining. Thank you everyone, and see you next time.
Thank you.
Thank you.
Very much.
Bye.
Thank you, Teresa, also. And
Bye.
Yeah.
thank you, Diana.
Bye. Thank you. Thank you. Bye.